So the process of learning tasks in rehabilitation starts off with initial learning of the task that requires conscious effort. So when a person has to relearn a certain task, let's say it's walking, or let's say again it's brushing their teeth, initially because they are now faced with an impairment, a weak limb, or poor balance, or what have you, it requires conscious effort, step by step, movement by movement, in order to regain that ability to do the task. And that's why the therapist is there to show and to the patient step by step, movement by movement, how to do that. Okay, so not only is there the need for the motor ability or the muscle ability to walk or to brush your teeth, you have to have the coordination of both the motor and the sensory aspects in order to do that. So when a person walks, he or she has to know where their leg is in space, where they are striking their foot on the ground, where the position of all their joints are, where their arms and legs, where their arms have to be. Likewise, if they're brushing their teeth, they need to be able to pick up the toothbrush, feel the toothbrush in their hand, and be able to bring it up to their mouth and feel the brush in their mouth and feel it, brushing the teeth. So this coordination has to happen. It's not just a matter of movement. It's a matter of sensory and motor involvement and coordination in order for the task to be successful. And with practice, the task becomes easier. As I said before, that's the reestablishment of the connections. And again, initially, it's very tedious. The therapist has to be there step by step, movement by movement, and the patient has to go over it again and again and again until it becomes second nature. So rehabilitation involves a whole lot of practice, which is repetition over and over. So some of the requirements for learning functional tasks. Oh, we can pause there. That's a lot to go over. Okay, part 3. So we've been talking about reconnections of the brain, reestablishment of neural pathways, and the need for initially conscious movement to get the connection at least established, and then repetition and practice to get it polished and fine-tuned and in a sense, second nature again. So some of the requirements for learning functional tasks, as I said before, however, it also involves, again, correct movement and technique. Also the avoidance of maladaptive behavior and movements. So that's why the therapist is important, because they will ensure that the patient does not adopt movement or patterns, as we call it, that will, although it may get the job done, eventually it becomes deleterious and it causes spasticity or joint destruction or pain. And so the therapist will ensure that the movements are correct. If the movements cannot be corrected just by proper movement patterns, then that's when splinting comes in, bracing comes in. But again, what we want to accomplish is to prevent poor habits that will eventually lead to further pain or disability. One of the other requirements is to use what is preserved, right? So if a patient, after sustaining a stroke, just uses the strong side, then the weak side will never get better, okay? And so you have to, the therapist will instruct the patient to use the impaired side as much as possible, to use what is left in order to preserve that function or, in fact, regain and improve upon that function. We'll go over that a little more when I talk about the constraint-induced therapy. One of the other requirements is the ability for the patient to have memory and carryover. So part of learning is the ability to remember what you learned, right? And the ability to carry over what you learned to advance to the next step of learning more things, right? And so if a patient has impairments in memory, say, for example, in dementia, where they have problems in remembering things from one point in time to another, or from 1 second to the other, or from one day to another, then think about it when the therapist works with the patient the following day and the patient can't remember what happened the day before, then you're starting at square one again. And so again, the patient has to have the ability to carry over and have memory so that you can build upon the process. And again, as I said before, repetition of movement, repetition of the therapy, repetition of the task is all key to improve that function. So some other keys to recovery. So the best prognosis in patients is that, in a sense, function which is preserved at the time of rehabilitation. So, of course, and it's pretty obvious that the more function a patient has preserved at the time of rehabilitation, the better the outcome. If a patient is totally hemiplegic on one side and doesn't have any residual function, then the prognosis, of course, is a lot worse than someone that has at least some ability to move the arms or legs. And again, we can work on that. So again, the best prognosis is the amount of residual function at the time of rehabilitation. Proper and timely therapy, I'll go over that in a little bit in terms of when it is best to institute therapy. Supportive environments, I'll go into that a little more detail. The ability to learn, memory, and carryover, I already talked about that. So you remembered that I talked about that before. See, so you have intact memory. For those of you who don't remember that I said that, well, not so good. No, anyway, also keys to recovery, motivation and persistence, as well as acceptance and patience. Okay. So recovery of function is seen most rapidly during the first 3 to 6 months of after the stroke. This is when, if you look at the curve, it is very steep in terms of recovery. This is the most chance in which a patient can recover as much function as possible. However, after 6 months, certainly there's continued improvement, but at a slower pace, a slower rate. And recovery can still continue even after that, even past 1 year. Data is somewhat ambiguous. However, if you ask most of rehab doctors, they have certainly seen rehabilitation progress past 1 year, past 2 years. I've certainly seen it even past 5 years. So you can always try, and you can always attempt to rehabilitate further. 50 to 75% of patients regain some ability to walk. That may be with an assistive device or bracing. And 50 to 60% regain some independent activities of daily living within the 6 months. What is classically thought is that the lower extremity function is much easier to recover than upper extremity function. So you'll see many patients who can walk but have significant disability in their upper extremities. There's various theories of this, and perhaps some of it may be related to demand. That is, patients feel more inclined to be able to walk than the ability to use their upper extremities because they have the other extremity to rely on. However, in walking, you pretty much need two legs to be able to um, walk easily.